Hello everybody, my name is Laura Wheatcroft. I am a paediatric advanced practitioner and I currently work at the Panda unit at Salford Royal Hospital, which is a children's A&E department with the ability to observe children for up to 24 hours as well. I've been there for the past 13 years, so I've got quite extensive experience with children ranging from 0 to 16 years old. I've been asked to talk to you today about bronchiolitis, which is quite a common presentation in the young children and infants that we see. The aims and objectives of this session, hopefully by the end of it, you'd be able to understand what bronchiolitis is, what the main causes of that are, what the initial symptoms may be and how these develop, and also recognising what we call red flags for serious illness, so the children that potentially could become very unwell from this condition, and hopefully to discuss the management of that and the evidence base that shows us why we do what we do. A quick tour of the background of bronchiolitis. So you may or may not have heard of it before or had any experience with it before, but it is a very common condition that we see in children under the age of about 12 months. It is acute inflammation of the bronchioles, which is usually, but not always, caused by a virus called RSV. You may hear the term RSV positive or negative. It doesn't change the management of these children or what we do with them. It just gives us an idea whether these children have this virus or not. It's very, very common during the winter months, usually from about November to sort of March time. Lots and lots of young children will present to the GPs and the emergency departments with this condition, so it is something that you will likely see. Usually affects children under the age of about 12 months old, can be a little bit older than that, but roughly about a year old. Initially, they will present with symptoms such as a cough and cold that worsen, and these usually by about day 3 to 4 will be at their worst, and that's when most parents or carers will bring the children to be assessed by the GP, the emergency department or walk-in centres, etc. Most infants, it's a self-limiting illness and it can be managed at home, and it's just reassurance and advice that the parents need. There are a percentage of children that will become more unwell and may need hospital treatment, and they're the ones that we need to be able to look out for and recognise in our practice. Most of the time, treatment is just supportive. There is no cure for it. It's a virus, so antibiotics, etc. aren't going to help. So supportive therapy is the way forward. Initial symptoms, as I say, may include coryzal symptoms for 2 to 3 days normally, so a cough, a bit of a runny nose, might just be a little bit not themselves, the children, but by around day 3 to 6 of illness is when they become at the worst. At this point, most children will have a typical bronchiolitis cough. You can find that by looking at videos on YouTube, etc. Most of them will have a wheeze, usually an audible wheeze that you can hear without the need for a stethoscope, and it can be quite impressive, and that's what worries the parents the most. When you do listen to the chest and auscultate the lungs, you will hear fine crackles throughout the lung fields, very noisy. Most children at this point will have some element of increased work of breathing. We'll talk about that on the next slide. They may or may not have a fever, usually a low-grade fever, 38, 38.5, doesn't tend to be higher than that, but it can be. Most of these children will present because the parents are worried about their feeding as well. They'll find that they drop off with their feeds. They may be taking a lot less than normal. They're becoming tired during their feeds. And if you think about it, when they're working harder with their breathing and then they're trying to take their milk from a bottle or from the breast, it's a lot harder for them. So they do struggle with their feeds quite a lot. Some children will be a lot more unwell and they may have apnea episodes. They may have cyanosis or colour change or become very pale, or they may be exhausted and sleeping a lot more, and of course worrying the parents. Other signs are of course tachycardia, bradycardia. You don't want either of those particularly, especially the bradycardia. That's a sign of quite severe illness. And when we're assessing them, we may find that these children have reduced oxygen saturations as well. It's not uncommon to find that. When we talk about work of breathing in these children, the things that we're looking for, that I would be looking for when I'm assessing them. What is their respiratory rate? Are they tachypnic? Most likely they will be a little bit. With regards to that, we then want to look at their work of breathing. So looking at the way they are breathing. Do they have what we call intercostal or subcostal recession? Are they pulling in around the ribs? Do they have a tracheal tug up here, pulling in at the neck? Not always easy to see in the younger babies because they do have quite a short neck and a big head, so it's not always something we can see. In those children, we may see head bobbing, something that the parents don't usually recognise, but you can see the little head moving up and down when they're breathing. You may hear what we call grunting as well. Usually in the expiratory phase of their breathing, you can hear them making a noise because of the effort that they're making with their breathing. In severe cases, as I say, you may see apneic episodes, you may see colour change, they may be mottled, they may be pale, they may be a little bit blue tinged, or sometimes they can be a bit grey looking in appearance as well. Coupled with, as I say, an audible wheeze, crackles throughout all of the lung fields, and usually some decreased oxygen saturations, but not always. The red flags that we look for when we're taking a history in these children, these are the children that potentially could become very unwell and have severe illness. As it says on the slide, up to 40% of these children may need intensive care support. So any child that's had apnea episodes or a history of apnea episodes or periods of colour change reported by the family or witnessed on examination. Premature infants are at increased risk just because of the development of their lungs. They may have chronic lung disease, pre-existing oxygen dependence. They may have other comorbidities that will interact with the bronchiolitis as well. Anyone with congenital heart disease, immunodeficiency, and various other comorbidities, as I say. Any child that is less than 6 weeks old, again, is at an increased risk of becoming seriously unwell. Again, they're still developing, their immunity is developing. They will find it harder to fight off this illness. If you're assessing a child, they've got a cap refill time, which is greater than 2 seconds. That's a sign that 1, we may be dehydrated, and 2, in a baby can be a sign of being quite seriously unwell. If you couple that with, for example, a blood gas, whether that is venous or capillary, you will see usually a respiratory acidosis, hypocarbia, if that's worsening despite the treatment, or if that's initially not looking great. These are the children that we need to be keeping in for observation and potentially providing support for them as well. Feeding is a big thing. Any child that's feeding less than 50% of its normal feed volume, whether that's formula fed or breastfed, these are the children that again can become unwell. They're getting all their nutrition from their feeds, and if they're struggling to get that feeds, potentially they're going to be quite poorly. These children we would want to keep in, just to keep an eye on them, support them with feeding if necessary. 50% is the rough cut-off that we use. So a child that's relatively well and feeding more than 50% or about 50%, we wouldn't worry too much. They will make up for anything they've lost once they are out of the other side of the illness. So mild bronchiolitis, as I say, these are the children that you'll mostly see. Majority of infants will present with this. Usually it's the parents that are worried, but we can reassure, and most of these children can be managed at home. You'll find that these babies are alert. They look relatively well. They're nice and well perfused and pink. They're feeding greater than 50% of the normal feed volume. Might be slightly reduced to normal. That's okay, as long as they're taking 50% or more, and they're having at least a couple of wet nappies during a daytime period. They will usually have an element of respiratory distress. It's usually mild. They may have a little bit of recession, but nothing severe that's causing you to be worried when you assess them. They will have a wheeze, they will have crackles. We know that that's part of the illness, and that's not necessarily a reason that we need to keep them in a hospital, as long as they're managing themselves. We're not going to be able to get rid of that wheeze and crackles in these children. So if they're feeding and they look relatively well, they're maintaining their oxygen saturations, they can go home. What we would advise these parents is that they need to keep a close eye if they feel the child's deteriorating, they're not feeding, they're looking unwell, they're pale, they're floppy, they're exhausted, their work of breathing worsens, then they certainly need to seek advice from either the GP or the emergency department. We do have community nursing teams in most of the areas around Greater Manchester, and they are a fantastic resource for these families. They can go to visit the children or make a telephone consultation to discuss the child, keep an eye on them over the course of the illness, and advise the parents if they feel that they need to be seen. Coupled with the parents' information leaflet, of course, so the parents know what to watch out for, typical signs and symptoms, what we don't worry about and what we do worry about. Moving on from that, we've got moderate bronchiolitis. So these are the children that potentially will require hospital admission and maybe a period of observation and review to see which way they're going. You'll find these children present with poor feeding, so usually less than 50% of the norm, or they may have a poor urine output, so they might have only had 1 wet nappy in the preceding 12 hours. They'll be more tired than normal, sleeping more than normal. they may be working a lot harder with their breathing. So as we said before, you'll find that they've got significant subcostal, intercostal recession. They may have a tracheal tug, they may be head bobbing, they may be pale. Usually their oxygen saturations are on the lower side, so less than 92% in air. They may be the younger children, or they may have some of the other red flags that we've discussed. Most of these children, you'll find they've got abnormal observations. So as I say, less than 92% oxygen saturations. They may be tachycardic, tachypneic. Most children are by the time they get to this point. What we would do with these children is we would admit them to the department. We would give them some oxygen to maintain the saturations above 92%. The way we give that varies depending on the child. Usually we'll start with a nasal cannula oxygen, 1 to 3 litres depending on that child, to maintain the saturations. If we're not getting enough through that, we may change that to a head box, or we may change that to high flow nasal cannula oxygen, which gives us the ability to provide more, whether that's humidified or not. These children usually require support with the feeds. If they've got reduced feeding, it's because they're tired and they're struggling with their breathing, so feeding becomes a chore. We can help them with that by giving them either little and often. We can syringe that in. If they're not managing, then we will move on to the next stage, which would usually be an NG tube. Parents get scared about these, but actually it's relatively untraumatic for these children having it passed, and it means that they're not putting the effort in when they're feeding. We can give them small volumes often, they're getting a nice full belly and they're not having to do the work, so they get a rest. If they're still getting worse at this point, then we may need to investigate things further. We may need to escalate the care that we give them. So we might consider at this point blood tests, blood gases. We may get IV fluids on board instead of the NG feeds if we feel that filling their tummies making their respiratory distress worse. If they're still worsening, then we may want advice from our consultants or from the NEWTS team, which I'll talk about in a second. We don't generally use things like bronchodilators for these children. They are young children, and there's lots of evidence to say that there's no effect of these, or no real effect of these. It's more about oxygen supported therapy and feeding therapy in these children. And then we've got the children that have severe bronchiolitis. These are the ones that obviously we worry about the most and potentially would require intensive care. These children will have all the symptoms that the moderately ill children will have, but they will be worsening, and they may have other symptoms as well. They may have apnea episodes, they may be grunting, they may have a reduced conscious level, they may have worsening blood gases, worsening acidosis when you look at these, despite the efforts that we're giving them oxygen. You'll notice that their effort of breathing initially will be worse. They'll be working very hard, their recession, etc., will be significant. But then you may find that this goes the other way and they have quite a poor effort, leading on to apneas. And these are the children that have the potential to arrest if we don't get on top of them. These will all be discussed with paediatric intensive care, or with the NEWTS team, which is the Northwest Transport Service for children that are very, very unwell, requiring intensive care. They can transport these children ventilated if needs be, and they have a hub of advice that we can conference call into and discuss the children as and when they're in our care. Usually at this point we've already got past the high flow oxygen or the nasal cannula oxygen, and if these children are worsening, we need to consider the next steps. That may be CPAP, sometimes a bit of PEEP, a bit of pressure is what these children need. If we're not getting anywhere with that, they're still worsening, and then it may be a discussion regarding intubation for these children. It doesn't happen often, but there are children year in, year out that we see that do require intubation because of bronchiolitis. If we're getting to that point, of course, these children are nil by mouth. We'll be giving them IV fluids, maintenance fluids to maintain their circulatory volume. We would probably chest x-ray these children just to see if there is an underlying bacterial infection that may be there. You never know, we can have concurrent conditions going on. For that reason, again, we might consider giving antibiotics. If these children are drastically unwell, it's not going to do them any harm to give them some antibiotics, and if we think there might be an underlying infection elsewhere, then we should definitely treat that. These children are at risk of developing sepsis and, of course, becoming very unwell with that, so we need to cover all bases. We'd be performing regular blood gases to assess their condition after the interventions that we're performing. We need to assess their observations on a regular basis. We need to keep an eye on their oxygen saturations, their heart rate, their respiratory rate, their conscious level. and a strict input and output with regards to fluids as well. Most of these children are going to, as I say, require admission to an intensive care unit. So the NEATS team are the people who can find those beds and transport those children for us if needs be. As I say before, medications and investigations vary depending on the condition of the child. There has been a lot of research and change in management over the years with regards to management of bronchiolitis. We used to give them all nebulizers, inhalers, that sort of thing. However, over the years, that advice has been, we don't use those anymore. Bronchodilators, salbutamol, ipratropium are not recommended as first-line treatment. There is no real evidence to show that they have a significant effect on the disease process in these children. They may come out of hospital a day or so earlier. However, it doesn't have a significant enough effect for us to be recommending that treatment. When you consider the development of these children's lungs as well, it's not surprising that salbutamol shouldn't really have an effect on these children with regards to the beta 2 cells that they aren't yet developing. Again, antibiotics are not recommended in these children, especially the mild and moderate illnesses. It's, as we've said initially in the slides, bronchiolitis is usually caused by a virus, so antibiotics aren't going to make a difference. The caveat to that is the children who are severely unwell, as I say before, we may want to consider antibiotics, we may want to consider trialling bronchodilators to see if these have an effect on these children following further investigations such as chest x-rays, etc. Again, we don't usually do blood tests on these children. Unless they're quite unwell, moderately to severely unwell, we'd start off with our gases to assess their condition. We may well do a full blood count, UNEs, etc. One to look for signs of a bacterial infection, looking at hydration status, etc. But in the majority of these children, they won't require blood, x-rays, or any medical treatment, medicine treatment. When we are looking at discharging these children, we have a criteria that we would want to meet. We want the child to be alert, we want them to be feeding at least 50% of the normal feed volume and having a good urine output. So we're looking at a couple of wet nappies in a 12-hour period as a minimum at this point. The work of breathing, they may still have a little bit of recession. That's okay if it's mild and they're well in themselves, they're a good colour, they're maintaining their oxygen saturations, they're not worsening, they're not becoming tired with it. Most of these children will have an element of recession, and that's not going to disappear until they've come out the other side of the illness. We want to make sure that they've got adequate support at home. So we might have a family where we've got a single parent who's got lots of other children, and they may struggle to keep an eye on this child as much as we need them to. Or we may have a parent that needs to go out to work and can't be at home with their child. We need to make sure that the child can be cared for adequately to be assessed for deterioration. That's where the community team can come in really useful. As I say, they can check in with that family, support that family, make sure that they're getting the care that they need, and visit if needs be to check on the child and make sure that the child is well in themselves. We always need to give parents some information on discharge, whether that's a leaflet that you might find in the trust that you work in, or there's lots of information on the NHS website that can be printed off and given to them. It gives them something to reference about children becoming unwell, what they should look for, what we worry about, what we don't worry about, and when they should return. And it's so important to safety net these families and make sure that they're managed appropriately. That's a very quick whistle-stop tour of bronchiolitis. I hope it's given you some idea on what we look for. There are a lot of resources. I've just listed a few on this slide here. So Spotting the Sick Child is quite a useful website, and it covers various different conditions. It's relatively basic, but it'll give you a good background on paediatrics and various conditions that we see. The NEATS website, they have lots of guidelines and management protocols on there, so it's always worth a look, and it's all the information about how to contact them as well. There's nice guidelines for bronchiolitis, which basically discuss what we've talked about in a lot more detail, so it's a good reference to have. There's information on the NHS website, both for parents and carers and for medical professionals as well. And if you're worried about breath sounds and listening to chest in these little ones, there's lots and lots of really good videos on YouTube which give you the sounds that you can listen to. And it's really good to just get an ear for those sounds. So listen to a normal chest, listen to a child with a wheeze, listen to a child with a bronchiolitis type cough, listen to a child with a croup type cough, and understand the difference between those. I can't stress enough how important it is, because there's so many different respiratory illnesses in children that we see, and just having a basic ear for what to listen for is really great. I hope that's been useful for you. If you do want to contact me, my email address is on the first slide. If you've got any information requests, that's great. Thank you.